So we're here looking at the concept of contact is control and control is safety. So in our patient positioning series, we already talked about negative space. The space between us is unstable. What we want to look at here is things that sew this all together. So again, contact is control and control is safety. We look at our palpation concepts and we talk about get as much as you can touch. Multiple things, even when we spoke about multi-sensory integration. The more contact we have, the more opportunity we have for multi-point discrimination. So what it all sews back to is the concept of broad contact. Now that broad contact also allows us not only to palpate more usefully or have more multi-point discrimination, but what it also allows us to do is to control the patient better and use less effort on the part of the practitioner. So this space becomes problematic. So if I want to work on my patient, I make contact, so I can lean into the table and get closer, and I can work on my patient. Now, if I lay my hands on, and I don't change the position of my hands with respect to my body, so it essentially looks like this, I lay that on my patient, I can control my patient fairly well. The challenge is, at this point, or from this distance, the only contact I have is my hands. So I have a much harder time with multi-point or distributed or dispersed multi-point comparison, right? So what I want to do, we've talked about this in our other videos, is I want to bring my patient back to me. So slide back to me. Okay, so we're actually going to slide forward. I just want to make something clear here. So as the patient is coming back to us, if we look at the legs as being bent to make sure that the patient is safer on the table, we don't need to control those as much. But if we look at essentially the torso of the patient, as they come back to us, if we have our abdomen roughly in the region of the high lumbar, low thoracic area, and we control the patient's shoulders and hips with our hands, we can do something like this. Slide back to me. Okay, bring your shoulders back more. Slide your shoulders back. Okay, so patient communication becomes a point of interest. But what I've done is I've removed a fair amount of the negative space. Now from here, because I don't have to go as far, okay, we want to be as respectful as possible and recognize that for some people, certain types of body contact may be less comfortable, and that's something that everybody is fairly aware of. But if I'm here, right, and I'm using essentially my belt buckle, and I place it in and around the patient's PSIS, posterior iliac crest, I can start to mobilize my patient with no hands, right? It may not be as visible, but if I walk up the body a little bit, and I essentially do the same thing in the patient's thorax, I can mobilize the patient. Now, if I was to do just this, this feels somewhat uncomfortable for many people. If I have my hands on, okay, if I have broad contact through the ribs so I understand what's going on, and I lean in, I don't push in, I lean in, and I lean my body in, so you can see my body wavering over my feet. So I move my whole body. I can start to control my patient in a very different way. So a lot of broad contact, multi-point discrimination, so I can really understand what's going on over a broad area. I have more control over the patient with more contact. Okay. So if we look at this, it was something like the pelvis. Now I don't know how well this will show up on the video. Okay, so what I can do is I can have my hand on the greater trochanter because it's a reasonable handle, it's a comfortable handle. Not many people will feel uncomfortable with it. I can push with my arm the pelvis up, so I can tip the pelvis onto the lumbar column or tip the pelvis towards the thorax, essentially creating softening of the lateral tissues or softening of the obliques, softening of the erector mass on this side. I can also at the same time create some lumbar side bending, whatever is available. We understand that minimal lumbar side bending is available. As an alternate to that, wearing out my arm, what I can do is I can actually take my thigh and my abdomen, depending on the size of the patient and the size of me and how we match up, I can essentially lean onto the patient. So we've shown this in seated. I lean onto the patient, I place my hand on the trochanter, I place my other hand in the lumbar column, so I've got a broad hand in the lumbar column, essentially a yoke. So along this yoke I get a lot of information, through my palm I get a lot of information, through my fingertips I get a lot of information. The thumb comes into the lumbar region, so I can be very kind of point specific on the thumb pad, but I've got a lot of contact here. I go ahead and I place my thigh and my abdomen in and around the patient's pelvis, my hand on the trochanter, and now without pushing, I can simply lean. The amount of movement present there may not be as visible in the video, and that's okay, but we can at least talk about this, the idea of contact. So if I wanted to move the patient's pelvis around, I have a few options that all come back to contact. Okay? So I can drape across the patient's pelvis. Now you see me having to lean for this. This isn't ideal, but the concept of I can pull him with my arm, or I can fold over my arm and just lean. So I still have the same surface contact on the patient, but now I just lean on my arm and I move my body. And my free hand for palpation can be gentler, softer, more attentive. So again, contact, broad contact. I can do a similar thing if I just walk in here. And again, I have my hand to steady, to feel. I have my up-table hand or my palpatory hand to work and check here. Now many may ask why I'm working from behind the patient, and the rationale there we've talked about before. Patient's closer to me, I can have more contact with them, more control, more opportunities for multi-point discrimination. The more I say these things, the more hopefully they have an opportunity to sink in, the more you have an opportunity to go in and understand them better. Now shift your shoulders back towards me. So now, let's just say I'm doing something like classic rib raising that you'll see in many textbooks. If the patient's further ahead of me, I have to lean in to control them. Take my good old yoke, match it to the angle of the rib, right? So in this patient, drawing the angle, it may not be perfectly visible, but I get in between the intercostal spaces or in between the ribs in the intercostal space. And I can just good old do this. I can have all this space between me and the patient. Okay? Work, connect lever to fulcrum. Now, I can also come in tight to the patient and stabilize the patient. And if I need to, so you see, as I lean in, I can create different motions. I can really start to use my body to help this patient out and really tune in to what we need to do. The idea of having more body contact, again, helps not only with control and safety for the patient, accuracy of the treatment, it also helps with multi-point discrimination. When I continue to say multi-point discrimination, what I'm saying is I have more contact with the patient. It gives me more sensory input, understanding that at varying points in my body, my accuracy in two-point discrimination is minimal, so my abdomen, my forearm, anything essentially other than my hands, lips, or toes, multi-point discrimination or two-point discrimination is not as accurate, but it gives me an opportunity to start it. So if I feel something on my abdomen that is not moving as well, at least I have the opportunity to now consider what's actually going on. I can move my hand, I can move my body to get more accurate or more in tune with that given area. So the key take-homes here are that in lateral, I often want to work behind the patient. So if we're considering patient positioning and how do I position the patient or how do I choose to position the patient, I want the anatomy exposed, free to move in the plane required, and preferably visible. When I'm behind the patient, especially if I'm working on the up-table side, it's much more visible. When I'm in front of the patient, so I'm going to have you flip over and face me. Now, if I'm here, to see the lumbar column or the thoracic column, not only do I have to lean in, bridge all this space to control the patient, which starts to hurt my hamstrings, hurt my knees, to see it, I have to look over the patient. Now, can I minimize that? I can minimize that to a degree. Slide towards me. There you go. As the patient slides towards me, I control them with contact. I stop him. Now, I still have all this gap between me and the patient. So I have to lean in to control the patient. Right? That starts to hurt my hamstrings. We start to hurt my hamstrings. We start to hurt my low back over time. So I want to be careful with that. So usually what you will see is I will suggest to people to work behind the patient in lateral. Not exclusively, but often. Because I have better opportunity to contact the patient, control the patient, have better multi-point discrimination, and better essentially direct the treatment more accurately. So we're looking at combining these concepts. So here, what we're calling this is contact is control, control is safety, but we're also sewing together all of these other concepts under the general umbrella of broad contact.